Hello, friends. Thank you for joining today and being here on time. Let's get started since it's 12:05. We are going to be doing a case today for which there will be a lot of participation on poll EV. So if you wouldn't mind just joining this, there will be another reminder slide in case you haven't had a chance to log on yet. So let's get started. Today, we're going to be talking through a case, a little bit diagnosis, and then mostly management and treatment for this case today. The objectives are going to be for all of us to be able to recognize an uncommon presentation of a common illness, to be able to apply Duke's criteria, and to revise plans as we gather additional information. So before we get started, just another reminder, the numbers are 549, and I can write that in the chat as well, so people who join later can have this information. But before we get started, this is probably only going to work for people that are logged on with their computer. Here I'm asking you to identify the chamber that is the left ventricle, and perfect, poll EV is allowing you to put in tags for where you think that is. And so go ahead and take some time to tell me where it is. Perfect, great work. That is the correct answer. And thank you for participating. So as we go on with our residency and training, you guys will get a lot of echoes, and it's helpful to be able to identify some common views on an echo and to be able to actually get good at doing these bedside, especially for our senior residents and those that are alone in the Denver Health ICU. And so today we'll just look at one of these views, and I will bring up more of these views in my presentations in the future, but today we'll talk about the parasternal long axis view, which is this view, and we're going to identify different chambers. You guys correctly already identified the left ventricle for me, but otherwise up here we have our ultrasound probe that's looking through the skin, and the first chamber in this view that we see is the right ventricle, sometimes also called the right ventricular outflow tract. Here's the left ventricle, which all of you showed me. Then we have the left ventricular outflow tract, and you can see the two leaflets of the aortic valve here. We have the left atrium draining into the left ventricle. Here, the aortic valve, as I already pointed out. Here, we have the mitral valve, and then here's the intraventricular septum. And so get used to seeing this view. We'll see this again later a bit in this presentation. So let's get on with our case. You are seeing a 24-year-old woman. She's evaluated in your clinic for cystitis symptoms of 4 days. She reports feeling hot, but no flank pain or vaginal discharge, sort of a routine presentation. Examination, vital signs are all pretty unremarkable. And here is your urine. So you do a dipstick in clinic, which is consistent with an infection, and then you sent that for micro, which has some white cells, some reds, bacteria. And so it looks like this is cystitis. And so my question is, what is our next best step in management? And I know it may seem odd that we're talking about cystitis, but I promise that it will make sense. Great, so I agree. I would discharge this patient with nitrofurantoin as well. And let's talk about pretty quickly about simple cystitis, and I won't spend too much time on this, but as Heidi Klum, I'm surely said about antibiotics, one day you're in, the next day you're out. And so what are some first-line therapies for this? Nitrofurantoin, as many of you said, trimethoprim sulfamethoxazole or Bactrim, phosphomycin, and oral beta-lactams are common things we use for simple cystitis, and so you guys picked the right answer. And the reason I wanted to bring this up is just to let you know that we no longer prescribe ampicillin, amoxicillin as first-line therapies because there's a lot of resistance to those medications. And then fluoroquinolones, while a decent second line option, is no longer a first line option either. So make sure you're picking from the left column. But, and I also wanted to bring up this point to teach you a little bit about nitrofurantoin. This is a question you're going to likely be asked, mostly in our outpatient setting. But just remember that nitrofurantoin accumulates in the lower urinary tract, mostly the bladder, after being excreted by the kidney. And so you cannot use that in patients that have renal impairment, urinary incontinence, or pyelonephritis because tissue penetration and blood concentration are negligible with this medication. It also actually is one of the medications where G6PD deficiency comes into play. So just remember this for the next time you get asked about nitrofurantoin. So moving on with our case, of course, this was not going to be a case of simple cystitis. And so the ED calls you and says, hey, I want to admit Miss P, the patient you had seen earlier in clinic. She's a 24-year-old female who comes in after 6 days of a completion of a UTI treatment, but here with recurrent UTI symptoms. And they tell you that she was septic in the ED, she had a low-grade fever and tachycardia, and she just didn't look good enough to discharge with this UTI relapse, and so I'd like to admit her to your team. So aside from giving IV fluids, what antibiotics should the ED give this person? Ceftriaxone. If you have a hard time logging into Poll EV, you can also chat your answer if you'd like. Okay. Seems that we all agree that it probably should be ceftriaxone. Yep, and I agree as well. So routinely for UTIs that need to get admitted, so maybe bank, yep. For the person that's had maybe bank, care to expand upon why? So routinely when the emergency department admits somebody for a UTI or pyelonephritis in patients that don't have a lot of pseudomonal risk factors, like a history of complicated UTIs, history of pseudomonal infections, recent instrumentation, sometimes diabetes, ceftriaxone is our go-to medicine. It's a third-generation cephalosporin. So I agree the ED should likely give this person ceftriaxone. So they give them IV fluids, they give her ceftriaxone, and she gets admitted. And while you're chart reviewing, here is what you come across. So these are some of her labs. I'll point out to you guys that her kidney function is normal. She has a little bit of a white count, some anemia, and a lactate that was 3.9, which has downtrended to 2.8 with some fluids, and then a very mild liver injury. Here's a repeat urine from this admission, which essentially shows what you saw in clinic, but now maybe with a little bit more of a red count, so some hematuria now. Okay, so what additional tests do we need to complete our workup in this patient that has been admitted with what is sepsis secondary to UTI? Blood culture. Great, great. And so remember what this question is essentially asking is, what do we need to do for patients who are admitted with sepsis, period? Great, chest x-ray. Yeah, good work, guys. So renal ultrasound, beautiful. These are some very thoughtful answers, and you guys are appropriately choosing tests to do which are standard of care for sepsis, but not getting above and beyond expensive studies that may not be helpful to us. So I agree. In this patient that now has a UTI relapse, we need to get a urine culture to see what's growing and susceptibilities, which usually come with if something grows. Chest x-ray, which is a pretty routine thing to do to make sure that there isn't anything occult in the chest, which may be causing sepsis. Renal ultrasound is a great answer because this patient has a UTI relapse of what we thought was appropriate therapy. It is not unusual to get a renal ultrasound in patients less than the age of 35. It is recommended in patients greater than age of 35. You could consider a CT as well. And then I saw blood cultures, which is correct. This patient came in with sepsis, had a lactate, and so would you get blood cultures? So good work. All right, let's see what happens. So you happen to be on your 24 during this case, so great. You're gonna get some of these results back yourself, and cross-cover won't have to deal with this. So later in your shift, you get a call to critical that the urine culture is growing Staph aureus greater than 100,000 colony forming units. So with this information, does this change nothing and you're just gonna keep going as it is? Or this changes a lot and I'm gonna need more information? Okay, looks like everybody wants more information. So now I want you guys to chat for me what pieces of information you're going to look for in this patient's history, in her exam, and what more diagnostic things you might consider checking right now. And tell me, if you answer in the chat, a little bit of your clinical reasoning and why you're doing the things you're doing. Feel free to unmute and just talk as well. Carl says, sexual history, drug use, and menstrual history. If grows in blood, automatic ID consult and echo. Great, Carl. What would you do for exam? I didn't really give you much of an exam rather than to say that she was febrile and tachy. CVA tenderness, great question, Tiffany. The patient did not have CVA tenderness. Agreed. Worried this would come from hematogenous seeding. Any signs of infective endocarditis? Great. So Sam, what signs are you going to be looking for? Splinter hemorrhages, Osler nodes, yep. Track marks, Carl, yep. Murmur, awesome, Sam, yep. So when I was doing lit review for this case, which is going to be of endocarditis, which you guys already knew from Corey's email, but splinter hemorrhages, Osler nodes, Janeway lesions are all actually pretty exceedingly rare and only happen in about 10% of patients that present with endocarditis. Most of the time, murmur is a pretty common one if they have a vegetation. So I definitely listen to the cardiac exam more carefully than you may have done the first time, or if the ED didn't get a chance to. And then anything on labs that I haven't presented yet that may point us toward a more serious systemic infection? Yep, Tiffany, that's exactly what I was thinking. So great. Okay, so here's some of that information for you guys. So you do some more chart review, and on history, turns out the patient recently relapsed into using IV heroin. So Carl brought that up. We need a drug use history from this patient. She does not use any alcohol, and she does not have any recent sexual activity. And when she does, she uses condoms. So that gets us most of that. As far as menstrual history goes, I forgot to put on my labs, but we did a pregnancy test, which was negative. And so then on exam, this patient continues to have low-grade tachycardia. She continues to have low-grade fevers. She has a 2 out of 6 diastolic murmur on her cardiovascular exam, but she has no edema. Her lungs are clear. She doesn't have any pleurisy when you ask. And her skin and nail exam is normal today. Remember, Osler nodes, I misspoke. Roth spots are similar vasculitic insults that you can find in a patient's eye exam. It's pretty hard for me to do a fundoscopic exam, but it's something you could think about if you needed more evidence. And I'd encourage you guys to think about it in all patients in whom you're considering endocarditis. And then objectively, our ESR is 80, and she continues to have mild anemia on repeat CBCs. Great, so you guys asked all the right questions. So now, having this information, I think we've already gotten some of the answers, but I want you guys to keep chatting what the next best diagnostic step is. And I think we've heard echo already, which I think is a great one. And would you change antibiotics at this point, and to what? So we'll say the answer to the diagnostic step is echo, which I think Carl already brought up. Great, awesome, yeah. I agree, Carl. The answer I was looking for was Vanc, and Alex, you said this too, Vanc. So we, really wouldn't need to do Vanc ceftriaxone until we have more information. But at this point, we would assume that the staph that's in the blood would be what was in the urine is likely what's in the blood from the hematogenous seeding. And so until we know if it's methicillin sensitive or resistant, we could do Vanc monotherapy. And great. So in the meantime, you're back on day 1.5 post-call, and blood cultures that were drawn on admission now are growing Staph aureus. The sensitivities are pending, and you guys have already done the correct thing, which was to switch this patient to Vanc until we find out what this is. But now this person is growing the same bacterium in her blood as well. So now we have positive blood cultures, and in light of positive blood cultures, what more orders do we need to put in for this patient so that she gets excellent care? We're getting an echo, so you guys can say that, but that's good. I think Carl mentioned this earlier, which I wanted to see, which is ID consult, absolutely. And then one other thing you should do to help yourself, awesome, repeat cultures in 48 hours. And so for this patient, put in an order for blood cultures every 48 hours, because these need to get done in a timely manner. And what I don't want to happen is for you to be off one day and forget to order them for that day. So just put that order in the patient's chart. Some work, you guys. Let me know if there are any other orders that I was missing, but that's what I was thinking. So at this point, you would get an echo, you would call ID, and you would make sure that you're going to get repeat cultures in 48 hours. You guys are killing it. Suboxone, Graham. I wasn't going to go into that in this case, but absolutely this patient who is using heroin needs addiction counseling, and hopefully for our addiction medicine teams to get involved. So great, good thinking. Okay, so instead of making you guys come up with this patient representation, I wanted to just give it to you because sometimes it's helpful just to see someone else come up with it. So what I have is a 24-year-old female with IV drug use disorder, admitted with sepsis due to Staph aureus UTI, now with a diastolic murmur and Staph aureus bacteremia concerning for bacterial endocarditis. So let's see what we do for her next. Okay, so whenever we think of infective endocarditis, we of course think of Duke's criteria. And the way I approach this is I ask myself, how likely do I think this patient has endocarditis? What is my pretest probability? And in this patient, from the problem representation alone, which I presented to you, our likelihood that she has bacterial endocarditis is pretty high. And so when your pretest probability is moderate to high, it is our job to reject each of these criterion and prove to ourselves that this isn't endocarditis. Until then, you have to do further investigation, diagnostic studies, repeated exams to see if the patient fits these criteria, making it a definitive diagnosis of endocarditis. So let's go through these step by step. So there are two major criteria. The first one of which is that the patient has to have 2 positive blood cultures with typical organisms. And these are staph and strep, and then the HACIC group. But this patient has a Staph aureus endocarditis, or bacteremia, sorry. And then Enterococcus is a common one as well, E. faecalis, I've seen a couple of times. So, yep, this patient has Staph aureus bacteremia, great. Then the other criteria is that there's echo evidence of endocardial involvement, which is typically valvular vegetations. And so in this patient, we have an echo pending to reject this criteria, that she does not have echocardiographic evidence. So we're getting that done. Next is, does she have a predisposing condition, heart condition or IV drug use? Yes, she does. Was her temperature greater than 38? Yes, it was. We know that she had fevers. Does she have any vascular phenomenon? Not that we know of yet. We haven't done a very thorough investigation, but she doesn't have any neuro findings. She didn't have any skin lesions. Her kidney function was normal, and she doesn't have any pleurisy, which rules out a lot of these small embolic infarcts. Does she have any immunologic phenomenon? Again, no kidney injury. And then I mentioned Osler notes, fat spots, which are in the eye. And we didn't check at RF, which I don't commonly think to do in endocarditis patients, but probably should. And then microbiologic evidence just means that does the patient have positive cultures but doesn't meet the first major criteria of common cultures. And then does she have serologic evidence of an active infection, things like a high ESR that's persistent, other signs of infection that may predispose to infective endocarditis. So having a urine culture positive for Staph aureus may put her in that category. And then remember, it's our job to reject these, but when a patient meets either 2 major criteria, 1 major and 3 minor, or 5 minor, then a definitive diagnosis of endocarditis can be made. And so we're waiting for that with our echo here. Right now, I would say we have maybe 1 and 3 minor, but really for sure 1 and 2 minor. So let's see if we can get the 2 major. So in the meantime, the culture's sensitivities result, and this is a methicillin-resistant Staph aureus, so MRSA, and you guys have already appropriately placed the patient on bank ahead of time, so good work with that. And so we'll continue bank therapy. ID agrees. And here we go. So our Transthoracic Echo, or TTE, is back. And now that we're a little bit used to seeing this parasternal long axis view, just to remind you, skin up here, RV down here, LV here, LV outflow tract, left atrium, and the mitral valves. Could one of our senior residents, or really whoever feels comfortable, tell me if they see any major vegetations or problems with the mitral valve here? Okay, in case, oh good, nothing that's obvious I'd be covering. Great, Carl. Yeah, so we're not used to seeing a lot of echo pictures. What I really want to do with this is encourage you guys each time you get an echo, just to try and seek out those echo images and at least look at the parasternal long view. And just look at as many mitral valve leaflets as you can to get used to seeing what's normal and what isn't normal. In this case, these images are of a normal mitral valve, and they're typically this thickness, and some of this abnormality is just from obscuration of the sound waves. And so the closing here is pretty nice. The two leaflets abut, and then opening wise, I'm not giving you the best picture, but this leaflet essentially goes all the way to the interventricular septum, which is where it's supposed to be. And so this picture is actually okay. Alex, this one I got from a normal echo, so I know for sure that these valve leaflets are okay. So just try and get yourself to look at as many of these as you can so that you get used to seeing what is normal and what isn't normal. Okay, so we are left with a normal transthoracic echo, or at least the views that we could get on this type of image. So the next most natural question that we all ask is to TEE or not to TEE, which is a transesophageal echocardiogram. And so what would you guys say in this patient? Should we get a TEE in her? Of course, a few days have passed as we've been talking about all of this, and her blood cultures remain positive. And so I'm here, Carl is saying, absolutely, TE sensitivity is like 50 to 60%. Yeah, Carl, great. And you guys can feel free to continue to share your thoughts, but you know that there are 3 leaflets to the mitral valve, and our transthoracic echoes are not great at visualizing all of them. There's a lot of tricky maneuvering, and frankly, some of the other valves are very difficult to see in that. And so in patients that have high likelihoods of endocarditis or have embolic phenomenon, things that cannot be explained by a small vegetation and are likely coming from a large mobile vegetation, you need to get a TEE. Additionally, this is a young, otherwise healthy patient, and so the risk of sedation and some of those other risks that come with a TEE are less in her, and so it'd be an even safer procedure to conduct. And so just some of the things I wanted to absolutely relate to you guys is that when there's a very high suspicion for vegetation, so like I said, embolic phenomenon, or when cultures are simply not clearing would be an indication for a TEE. When there would be a change in management, so if you would get surgery involved per se, then you should get a TEE. And then always discuss the risk and benefits of ID and cardiology, and the 3 teams together can come up with a consensus on how beneficial a TEE would be in this patient. And so for our patient, we get a TEE, and this is what we see. And so she has a 1 centimeter by 1.2 centimeter mitral valvular vegetation. So pretty large vegetation here. Okay. So then my question is, knowing what we know about this patient now, MRSA endocarditis with the vegetation, how long should we treat endocarditis? Great, awesome. So a few caveats here. This question and this treatment modality, or sorry, treatment duration is really for left-sided endocarditis. And the correct answer here is that it's 4 to 6 weeks from the first negative culture. So often you'll have patients that have 3 or 4 positive cultures, and so all of that time, that antibiotic duration doesn't count. You have to wait until the first negative culture. And really, that's why if after 5 to 7 days of appropriate antibiotic therapy, the cultures haven't cleared, you should start thinking about, what am I missing? What more do I need to do? This idea of antibiotics followed by suppressive antibiotics is more something that we see in infections like osteomyelitis and chronic skin and soft tissue infections. Very rarely we have done this for patients who relapse with their IV drug use, and have already gotten a prosthetic valve, and the risk would be high that they would end up infecting that valve. Sometimes they do get suppressive antibiotics, but of course that's a decision that you're going to make with your ID column. The correct answer here is B, 4 to 6 weeks from the first negative culture. And this is all IV therapy. There was, I'll write this in the chat, which you guys can look up. There's a trial out of Denmark in 2019 called the POET trial. And what they looked at was, can we treat endocarditis with 2 weeks of IV therapy followed by 2 weeks of oral therapy? The oral therapy group was non-inferior to the IV therapy group, but what ended up happening was that they only randomized about 20% of the patients they screened. They only had 4 or 5 out of the 200 participants were IV drug users, and so only 1% of the population was IV drug users. 0% of the population in the study had MRSA endocarditis, and this is an entity we see pretty often, and so not necessarily generalizable to the MRSA group. And this was a referral center, and the patients were referred by other physicians, and there was quite a bit of referral bias. And so ultimately what ended up happening was that even though the oral group was non-inferior to all IV therapy, no IDSA recommendations have been made off of this trial, and so we still do all IV therapy for endocarditis. You guys feel free to look up this trial, but and you may hear whispers of oral therapy, but we do not do that right now. Sometimes you guys will hear these words, antibiotic jail. It's really for patients that have IV use disorder, drug disorder, who we do not think would reliably be able to do these antibiotics at home. They need to be in the hospital. If there's a lot of concern for AMA or that the patient may not remain in the hospital, you guys may have heard of the vancomycin cousin medicine that you can give as an IM injection, and it lasts for 2 weeks in the system. And so often we use that. The name is escaping me right now, but that is an option that you can use as well.
Dalbavancin.
There you go, dalbavancin. Thanks, Jen. Great. So the last thing I want to talk about is nobody chose C, which was that until patient gets surgery, which is correct. But then we should ask ourselves, when should we think about surgery in patients like this? For example, Ms. P had a pretty big vegetation, so 1 centimeter by 1.2 centimeters. I mean, I've always heard that greater than 10 millimeters on the left side means you absolutely do surgery. And that's not absolutely true. So let's go through some of the surgical indications for when we should involve CT surgery for endocarditis patients. And I like to think of these in these 3 large groups. So either a patient has heart failure, they have an uncontrolled infection, or we need to prevent embolism. And so the heart failure ones are pretty obvious. Most of them are emergent indications. And essentially what ends up happening is that you have left-sided endocarditis, aortic or mitral valve, and you end up blowing the leaflet entirely. You got a ton of regurgitation, which causes either pulmonary edema or cardiogenic shock. And these patients need emergent surgery. So make sure that you're evaluating these patients carefully, looking for signs of edema, looking at JVD every day, listening to their lungs every day, and making sure that they don't have any signs of right or left-sided heart failure, because that would be an indication for emergent surgery. Then we have uncontrolled infection. I already mentioned this. Locally uncontrolled infections like abscess. Sometimes if you have tricuspid endocarditis, each patient can get 3rd-degree heart blocks. These are the types of indications for which they would need surgery as well. And then I mentioned that if their blood cultures are persistently positive for more than 7 to 10 days, I've also seen 5 to 7. It sort of depends, discuss with your ID colleagues. But at some point, you can't just keep going with the same antibiotic regimen that you have. You have to start thinking about source control, which is really this big vegetation that they have, or small vegetation if it's poorly penetrated. And then finally, the prevention of embolism. And so here is when, if you have vegetations that are greater than 10 millimeters, then you either have to have embolic phenomenon or you have to have complications like heart failure, persistent infection, or abscess, in which case greater than 10 millimeters buys you a surgery. Or if you have vegetation that's more than 1.5 centimeters or 15 millimeters, that's an automatic indication for surgery. Sometimes the sizes will differ by left-sided versus right-sided vegetations. We allow for the right-sided vegetations to be a little bit larger than the left, just because the left-sided ones cause more embolic events. Okay, so with that, I just wanted to bring it back to our objectives and see everything that we covered today. Is we recognize that Staph aureus bacteriuria is uncommon and that you need to do a thorough history and exam for these patients. And so remember, like Sam said earlier, this bacteria usually happens from hematogenous seeding. And so make sure you're doing joint exams to ensure that this patient doesn't have septic arthritis, that this patient doesn't have osteomyelitis, and of course, endocarditis like this patient. We talked about Duke's criteria, and so just remember that when you're suspicious for infective endocarditis, it's your job to reject each of these criteria, and so you have to think about it thoroughly and use some of your type 2 thinking to make appropriate decisions. And then finally, we revised our plans as we gathered more information, and so we appropriately broadened our antibiotic to vancomycin until we knew what the species was. We made sure that we got Q48-hour blood cultures and that we're monitoring for signs of embolic events or heart failure, because then we need to get CT surgery involved. And we would get them involved early because Staph aureus endocarditis has a pretty high mortality. This patient in particular had some of the other risk factors, which are female gender, large vegetation, left-sided endocarditis, all of which are poor prognostic measures. And so in her, it'd be important for you to even call them initially and say, hey, we have this patient, just wanted to let you know about her and see if there was anything else you needed. And that's what I have for you guys today. Feel free to secure chat me any feedback you have. Otherwise, this QR code is a very short 3-question survey. And I'd love to hear your thoughts and what sorts of cases you'd like to see moving forward. So what questions can I answer for you?
Hey, Sneha.
Yeah, Ben.
Great presentation. I think one thing that can get overlooked is the EKG in these patients too, especially on presentation. You really want to look for any conduction abnormalities at all. We had a case my intern year where we had a patient come in and she had a type 1 heart block and ended up going into complete heart block and unfortunately passing away. And if you looked at her EKGs, if that was picked up earlier, you could actually see it prolonging as she had infiltrative endocarditis into her conduction system. So something that can kind of point to like a more serious, if there's any new conduction abnormalities, you really want to make sure you're pointing those out.
Great, thanks, Ben. Yeah, absolutely. I mean, these patients will be on tele by way of being septic initially, but make sure you keep them on tele for the point that Ben made to catch any of these bradycardic or block events. And it may not be, unreasonable if the cultures are remaining positive to on day 2 or 3 or every 2 or 3 days, just get another EKG to make sure you're not missing infiltrative disease into the conduction system. Thanks, Ben.
And sorry to harp on this again, but these patients come back and die of recurrent endocarditis because no one treats their IV drug use, and they leave the hospital, do IV drugs, and come back. So please consult addiction, and you don't need an addiction consult to start Suboxone if you're there on the weekend, or if they're not in-house, you can just start it. You don't need an X waiver. So please, please, please just start them on something so they're not going to AMA on you. Those are the most heartbreaking cases of my residency so far, is these young kids dying of this.
Yeah, the reason I wanted to bring up this case was I have also had cases where essentially you are like begging CT surgery to take these patients to surgery and they refuse because either this person has a prosthetic valve already that they ended up reinfecting, and then CT surgery will just say, nope, we won't take them. And I've had cases where we've had to call CT surgeons that were not at our institution to say, hey, would you consider doing surgery in this patient? And that's a situation that is really heartbreaking and hard for the patient. And so try your best to advocate for them. And I think advocating for them means making sure you're treating their substance use. Thank you for that point. Well, thank you, everybody. Hopefully you get a chance to do this survey, and otherwise I'll see you on Zoom next Monday.